Namaskara, Ayubowan, Vanakkam everyone. A very happy first birthday to the Global Network for Health Humanities in Sri Lanka. My name is Satyendra Singh, and today I'll be talking about advocacy in health professions, education, and practice, the potential of health humanities. Long time back, Rudolf Virchow said that medicine is a social science and politics is nothing else but medicine on a large scale. The physicians are the natural attorneys of the poor, and social problems fall to a large extent within their jurisdiction. 10 years ago, a survey in the United States of America found that only 25% of physicians claim to engage in political activity on local health issues beyond voting. Similarly, medical trainees were found to be short of not acknowledging social justice or advocacy among their first professional responsibilities. Globally, there are a lot of movements or campaigns. We have seen He for She, the solidarity movement for gender equality, the feministic movements, We Can Do It, That Lives Matters, Black Lives Matter, Nobody is Disposable campaign for COVID-19 triage, Crypt the Vote for Inclusive and Accessible Elections, LGBT rights, and the Me Too campaign. But I would ask a larger question. Should advocacy be a mandatory part of health professions, education, and practice? An even larger question is, where are the patients' voices in health professions, educations? We have seen global movements, but where are the movements for patient voices to be there as prominent stakeholders in HPE? This is a very poignant poem written by an anesthesiologist postgraduate trainee from PGMS Rata Kamna Kakkar, which was published in our Medical Humanities journal Rhyme. The topic is about do not attempt resuscitation. She writes, and I read. When I die, just let me die. Don't put in any tubes or pipes. Don't push in breaths against my will and food through punctures in my skin. Don't wait for me to open my eyes. Don't ask them when, how, and why. Don't dare drug me to paralyze. Don't undress me if in peace I lie. Let death be my final wish. Let hours be my final kiss. A lifetime of gaze honored, admired. A vegetable isn't how I want to be retired. Don't let yourself suffer anymore. It will never be the same again, I'm sure. As I choose my kind of grave, you could choose to be brave. Let grief wound you once or twice. Don't let it be your way of life. So, no hospice when the time is near. I have chosen to be at home, my dear. Dignity in death. In Madhya Pradesh and Chhattisgarh, way back in 1979, a government order disallowed members from the particularly vulnerable tribal groups, Baigya community, from accessing family planning options. The thinking and apprehension at that time was that these communities have a declining or stagnant population and needs to be preserved. This forced many women to contemplate going to the neighboring states to get sterilized, but they have a characteristic tattoo on their forehead revealing their identities. The repressive and archaic order was later revised, but with a rider. They need to take permission now from the STM, which violated their right to privacy. Finally, 8 Baigya women and 2 Baigya men, along with a few doctor activists, filed a public interest litigation. Ranichand Baigya was 26 at the time of filing and already had 8 children. Courts finally allowed them their rightful due. Another group of vulnerable people is the transgender community. One of the Sri Lankan trans men told this about the staff at a few of the public hospitals in Sri Lanka. The words are more piercing than needles. Similarly, a transgender consultant of a super specialty, when she visited a hospital in Puducherry, she was stopped by a postgraduate trainee. And she said, Doctor, we will be charging you for your treatment here. Normally we don't. But our head of department says if we allow you, more people like you will be coming here. Later on, two transgender doctors shattered the stereotypes and myth when they were involved in a transgender inclusive nursing curriculum, which was launched, and they were the facilitators over there. The question which many times patient voices ask is how can I make a difference to society to change their perception when many people aren't seem to listening? Should there be a different path? And Angel Kafel from Kathmandu, an intersex activist, found the path when she turned to arts. She now advises the community with the power of the arts, and she has launched a project from color to commitment. Allegra Walter was the first openly trans woman doctor in Indonesia, but she received anonymous messages to repent to God with a link to websites offering conversion. Similarly, in the conservative nation of Pakistan, Dr. Sarah Gare is the first transgender doctor who is committed to change the curriculum to make it more inclusive. From India, Dr. Trinitra Haldar Gumaraju was denied hostel accommodations when she came out during her medical education, MBBS. The queer community is not only facing access to health issues, but also in physiological parity and dignity. The issues are beyond fairness. The issues are of ethics, the ethics of inclusion of transgender intersex athletes. Shanti Soundarajan was the first Tamil woman to win a medal for India in the Asian Games. She won silver medal in Doha Asian Games, but her medal was stripped off because it was found that she is an intersex woman. She writes, I grew up normal girl wearing salwar, kameez, skirt and a bindi. Long hair, flowers in my hair, bangles, etc. The Asian Games changed my life forever. I tried to hide from people, unable to face the humiliation. I attempted suicide and changed the way I lived. When I dress as a man, they don't see me differently. I am accepted. Similarly, from the intersex community, the professor of urology at the University of Texas at Austin Dell Medical School finally said that as part of the surgical community who cares for intersex patients, I want to publicly apologize for our wrongdoings. We see that intersex children many times have to undergo unnecessary sex surgeries. In India, in Delhi, three of us, myself, Dr. Sanjay Sharma, and Dr. Aksa Sheikh, one with a lived experience of a disability, another a proud father of a transgender woman, and the third a transgender doctor, we all filed a petition with the Delhi Commission for the Protection of Child Rights that unnecessary medical surgeries, specifically sex-selective surgeries, should be banned on infants and children, except in case of life-threatening situations. And the DCPCR agreed with a proposition and they advised Ministry of Department of Health and the Government of Delhi to ban such surgeries. We later wrote an article in Indian Journal of Medical Ethics that why intersex conditions should be viewed as differences of sex development rather than disorders of sex development in line with human rights and patient care framework. Over the period of years, I worked with a year initiative for health advocacy and research at Sangat Bhopal. And it was a great learning curve because we have worked on numerous projects, very diverse projects. For example, like Queer Chronicles. This is a project where we are working on developing first-person narratives of queer communities using arts-based methods. Another one, Rainbow Med, is a project to empower health professionals in India on LGBTQI plus affirmative care. Access Matters project is basically a participatory action research on accessibility audits of health facilities in two big states of Madhya Pradesh and Goa. Another one is about adapting the WHO-based framework for transgender, intersex, and disability communities. The next is disability inclusive compassionate care, where we are training medical educators on how to understand disability competencies from the field of health humanities. And another interesting project is about quinship, which is about the elderly queer people in India, what is their understanding of kinship. The basic theme underlying all of this project is, which I've also learned over the period of time, is that we need to talk about cross movement solidarity. Health professionals need to talk about cross movement solidarities because we learn a lot from other movements, be it the Black Lives Matters, the Dalit movement, the feminist studies, the disability studies, the transgender LGBTQI community. There is a lot for each of us to learn from each other and each and every movement. This is a photograph which highlights why we need to talk more about health humanities. A child with visible disability, and you see the Health Minister of India and the Chief of World Health Organizations and the top ministers from the Ayush Ministry gazing as a person with disability. This is a visual rhetoric of disability, and the very reason why disability competencies needs to be rooted in disability rights. This is a brutal display of how our disabled bodies continue to be medicalized, exhibited, photographed, and gazed. And this needs to be changed. And this is not a such problem only in the global south. It is the same issue in global north also, because we keep on seeing university students with disabilities outlawed in a corner, segregated, discriminated against because of inaccessible classrooms. You see the same situation where medical students with disability who wants to become doctors needs to be carried along with their wheelchair by their parents because the medical institutions in the country are not accessible. This is a very poignant narrative from a medical student with a disability in JAMA Neurology. What's wrong with her? She writes, as a teenage medical student in Britain, I witnessed symptoms of mine being discussed disparately in lectures and seminars. I would hear my adolescent colleagues laugh to one another. If I ever get that way, kill me. My cheeks would burn. Our teachers, consultants, and lecturers did not correct them. A senior professor of ops and gynae at my world famous medical school aggressively insisted to my class that everyone with my diagnosis should be aborted because they didn't like our quality of life. The professor did not know that I was sitting in the front row with that very specific condition. What a doctor looks like. We all have images of a doctors, and these are the images which are defying that perspective, that stereotyping. All of these are very prominent doctors with visual disability as well as deaf blindness. They are working with their dignity intact in the colleges in the US, the UK, as well as in India. And the emeritus chair of ophthalmology of University of Wisconsin said that not only do these gifted disabled physicians benefit medicine, sciences, and their patients, but their classmates learn from them. They gain empathy for people with disabilities and learn a lesson in courage. Last December, 6 months ago, I wrote this piece in the Lancet with my colleagues where we specifically highlighted that why disability training needs to be delivered by those having the lived experiences, that is, the people with disabilities, in conjunction with other health workers. And we gave an example of the advocacy because based on the lived expertise we have in consultation with doctors with disabilities, disability rights activists, and medical educators in India, framed disability competencies rooted in disability rights, which are 8 of which are now part of the competency medical education curriculum in India. And these are mandatory. Now pay attention to the competency number 6, advocate social inclusion by raising awareness of human rights of persons with disabilities. Following on our lead, the National Council on Disability in the United States, which is a federal agency on disability policy, has written in 2021 to both the ACGME and the Joint Commission to include disability competency training of all medical professionals. And most recently, the most evidence-based document from the WHO, the 2023 Global Report on Health Equity for Persons with Disabilities, very prominently says that include persons with disabilities in health and care workforce. They further says develop disability competencies for all healthcare workers. We've used Humanities to use a very powerful tool of photo voice stories. In this project with I Hear Sangat on photo voice, we gave voices to the voiceless. We empowered people from the disability and the transgender community to use photographs document, the attitudinal barriers. And you see that in this photograph, after struggling for a lot of time to have at-home vaccination, a person with disability, a wheelchair user, was finally given vaccination at home. But again, then you can see that, just for a photo op opportunity, the nurse is hugging the person, again, putting her in danger. War is happening in Gaza. And my colleague and co-founder of Health Humanities group at UCM, Supreet Dhaliwal, in a poetic editorial in the Rhyme this year, writes, when people are at war with themselves and the world is caught off guard, the healthcare professional steps in and gallantly fills the void. This is a beautiful photograph taken by Giles Tully. This is a photo of Mariam holding on to her father's finger, which was clicked at Gaza. A photo of a daughter who is looking for security, holding on to the hand of her father, who just wants to protect her. That surely should be a universal right. The recent case of former Delhi University professor Chien Sai Baba, who is also a wheelchair user with 90% physical disability, underscores the systemic barriers faced by prisoners with disabilities or accused with disabilities. He was arrested and put up in jail by police in 10 years ago, 2014. And finally, he was acquitted this year in 2000 by the Supreme Court of India, who said it's a hard-earned acquittal. How many years has the paraplegic man spent in jail? And this is his personal testimony when he came out of the jail. I was in the under cell in a solitary confinement for 9 long years on a wheelchair, without a wheelchair. It was a daily struggle to use the toilet, take a bath, or even fetch myself a glass of water. The prison doesn't have a single ramp for people like me. Now my heart is functioning at 55% due to HOCM. I suffered 2 attacks of COVID and one of swine flu in prison, but was not provided emergency medical treatment. I was provided medicine sent by my family only after my 10-day hunger strike inside the jail. I was refused permission to meet my dying mother or perform her last rites. Is the state's role to serve people or crush humanity? In jail, I was treated like the biggest terrorist in the world. 4 years ago, numerous disability and human rights organizations began sending straws and sipper to the Talota jail in Mumbai. This action was prompted by the imprisonment of 84-year-old priest and tribal right activist Father Stan Swami, who lived with Parkinson's disease and required a sipper and straw to drink water and tea, but was repeatedly denied by the jail authorities. Also, a review in the journal Lancet disclosed that medical professionals in prisons not only falsify death certificates to hide detainee killings, but covered up evidence of physical abuse. The use of solitary confinement has proved to have deleterious effect on the well-being and mental health. In fact, the World Medical Association has passed a resolution that it should be utilized sparingly and only in extraordinary circumstances as a final option. Long time back, Eleanor Roosevelt said that where, after all, do universal human rights begin? In small places, close to home, so close and so small that they cannot be seen on any maps of the world, like the Taloja jail or the Endasil. Without concerned citizen action to uphold them close to home, we shall look in vain for progress in the larger world. And in our article in the Indian Journal of Medical Ethics, we requested health professionals that the principles of medical ethics pertaining to the responsibility of physicians in safeguarding prisoners and detainees against torture and other forms of cruel, inhuman, or degrading treatment should be integrated into health professions education. And there is a reason for that. If you look at the General Medical Council UK's professional capabilities, you will find safeguarding vulnerable groups right there. If you look at the 7 CANMATS rules framework, you would find a health advocate right there at the center. If you look at the National Medical Commission's 5 role of Indian medical graduate, you would find a lifelong learner over there. In fact, in the past decade, based on our workshops in medical humanities and health humanities, we have proposed ABCDA paradigm for health professionals, which should be the need to have an analytical attitude, ethical and professional behavior, effective communication, respect for diversity, and be empathetic and ethical, which are in sync with the competencies which are there globally. In fact, based on our use of health humanities over the past 10 years, we have framed up humanistic competencies which are required for future health professionals, and they include narrative competence, critical reflexivity, visual literacy, structural humility, and yes, the most important one, advocacy. Finally, to summarize, this is the photograph from the beautiful Sri Lanka. And if you ask me my definition of health humanities, it would be what Rebecca Garden suggested. The medical or health humanities are, in essence, a form of advocacy, a means of addressing underrepresentation. It is to give voice to the unknown, to new perspectives that are personal and individual, to expose and make visible the complexity and intersectionality of patient lives. Thank you so much.